I've been asked today just to talk a little bit about tools and methods for capturing the patient experience, and I see some familiar faces around the room that I'm sure are very familiar with some of these. And so it's really just a whistle-stop tour of some of them, and we'll be doing a couple of activities, and then if you have any questions at the end, I'll be more than happy to answer them, or at least direct you in the right place if I can't answer those questions. As Jacqueline said, I'm part of the Partners in Care team, and what we're all about is ensuring that patients, family and whānau are at the centre of the care they receive, and that at all levels of the system they have a voice. So that's one of the key principles of our program, and also a key principle of the Health Quality and Safety Commission. So really experience, what are we talking about when we're talking about experience? Well, it's really, unsurprisingly, a person's thoughts and feelings of the journey that they have. But we're really, of course, talking in the sense of the clinical setting. But the clinical setting is pretty varied, and whether it's the clinical journey, the personal journey, or the emotional journey, and really just looking at those experience. Even just words like whether someone's feeling delighted, whether they're feeling underwhelmed, whether they're feeling frustrated at the various points on the journey. What does that actually mean? And how can we do something about it and incorporate it into our work when we're doing co-design? And the evidence is very clear on capturing experiences. And when we first started the program, we would have said that there's a growing body of evidence to support co-design and to support involving people in the community at every level of service delivery. And now we'd say it's a really established body of evidence, because experience and evidence has shown that actively involving health consumers at all levels of the system, not only does it assist with identifying care that is most likely to be acceptable to consumers, it identifies areas where waste can be reduced, or services can be reconfigured to ensure that people use them. It also ensures that consumer rights are upheld, and that the chance of harm is reduced. And I'll just pause and have a note on the word consumer, because we do always mention this. There are some people that really don't like the word consumer when talking about working with communities. And so what we always say is, whatever you relate to, whether it's a person, family, whānau, caregiver, consumer, tangata whaiora, any of the terms that really matter to the people in which you're speaking with is really the right term to use. We've just really put a line in the sand and said, for the purposes of all of our documents and everything that we do, we say consumer, but we do recognise it doesn't actually work for everybody, and in some cases that word can even alienate some people. So it's really just whatever works in the situation that you're in. So we also know too that patient experience, clinical effectiveness and patient safety are all linked. So of course, sorry about that, but of course from the standpoint of the Health Quality and Safety Commission, improving on all of those things is really important. And so, one way that we can do that is to make sure that we have the people that access services involved in designing those services. So there are many ways to capture experience. We don't have time to go through absolutely all of them. Some of you will be familiar with some of them and maybe not so familiar with others. And really a lot of them are common sense ways to collect what people are thinking and feeling, what their experience is, how their experience has been shaped. They're all the way from the quantitative to the qualitative, looking at complaints and compliments, patient stories, focus groups and panels, in-depth conversations, shadowing, storyboards, surveys. There's just many ways, and really it's about which method really works for what you're trying to achieve, which one is the best one tailored for you. Because it's very important to us, one size doesn't fit all, and so that doesn't just apply to your projects. It applies also to the type of methods that you would adopt. So I'm not just going to stand here for a whole hour and talk to you about methods. I think it's important to get some group participation. Now, some of you in the room might be familiar with this next activity because I see some familiar faces, but we'll go with it and we'll talk about it. So, this one is about thinking about your last experience at a shop. Now, it's deliberately away from medicine. So if you think about your last experience at a shop and you think about it being from worst to excellent, so we've got 5 categories basically: worst, poor, average, good, or excellent. So really, if you were going to put numbers on that, so you'd probably go from 1 to 5. So you'd go 1, 2, 3, 4, 5. So think about your last experience either at a shop or when you were with some friends in a shop, or it doesn't, it could be the supermarket, it could be anywhere really. So how many of you, if you were to with a show of hands, would rate it at number 1, the worst? No one had a terrible experience. That's good. What about poor? Yep, there's one hand up for poor. What about average, number 3? Okay, a few of you, number 3. A good experience? Yep, about similar amount, maybe a little bit less. And what about an excellent experience? Oh, that's good. I must hear about that afterwards. So, when we just quickly poll people about what they think about something and what their experience is, yes, of course it has merit. So we know that in this room, many of you are really, if we looked at a bell curve, you'd really be around the centre of that bell curve in terms of experience. But that's kind of all it would tell us. It would tell us that in distribution of people's experiences, most people roughly sort of would rate sort of in the middle, and there's outliers on either side. That's kind of what it can tell us. But really, there's more that we can know about this experience. So if you're still thinking about your last experience in a shop, and I may need some help here with the numbers, what I'd like you to do, and maybe instead of doing it in pairs, given the amount of tables, you could do it at tables. So maybe, or in pairs at tables, let's do in pairs at tables. I wasn't sure how many of you would be here today. So one of you is to discuss why you gave that rating, whether it's that 1, 2, 3, 4, 5, and the other person who's listening, just note down the experience, just note down some key words about that experience, and then do that for 2 minutes, and then swap over to the other person. So I'll get a timer on that one. So if you just pair up, so think about that experience in the shop, how you felt, why was it good, why wasn't it good, what was good or bad about it, and go. So now stop and swap to the other person for two more minutes. Okay, so that's 2 minutes on both sides. So does anyone want to share their experience with everyone, or what they got out of talking about that experience just for 2 minutes? It's not compulsory. Okay, well, I think I heard that yesterday there was a similar activity, and it was about thinking about a tea room, thinking about your tea room. Yeah. So you probably already pretty much picked up why we do this, and it's really because we hear a lot in these co-design projects that people do not have time. So if putting a team together, say we don't have time to listen to people's experience, it's too time consuming, maybe we'll just do a quick survey and we'll do a scale of 1 to 5 and we'll see what we can get out of that. But really 2 minutes is really not that long. And in 2 minutes you can get so much information from a person, and so much rich information, that really the scale has its place. Of course it has its place, but in reality, what is it going to tell you? It's going to give you maybe a bell curve, and that's what it's going to give you in this particular case where we're thinking about capturing experience, whereas this other approach, just a couple of minutes with a person, is different, and it can make all the difference. But I do say, to temper that of course talking about a shop is a pretty light-hearted sort of a topic to talk about, or talking about an experience. Some of you might know this activity from, what's your experience in a restaurant, or that activity yesterday. So it's easy to say, well, 2 minutes talking about that, we can get so much information. But I mean, it could be that, as you're all aware, you're talking about something a lot more serious and a lot more deep than that. And so I do acknowledge that, a couple of minutes here, you may need, of course, a lot longer, because you don't know where the conversation's going to go and what that might open up for someone. So, but even 10 minutes, 15 minutes, of your time to capture that experience early on is going to, will make a huge difference to the projects that you've all been doing. So yeah, this is going to be a very quick and efficient presentation, I have a feeling, from the... So I wanted to go through, not all, but just some other methods that you could use, and some of you may be familiar with, for capturing the patient experience. So one of these is called shadowing, and really that is exactly as it says. It's following somebody around who's having an experience, maybe through transitions of care, for instance, and really noting down at each point what it is that's happening for that person at different points in the journey. But important about that is it often actually needs two people in order to listen and capture. So doing that activity, that's what you might need. And of course, it's also going to need the buy-in from someone to be willing to have one or two people following them around for the duration of this journey. But it's amazing how much information you can get from following a person around and seeing what all of the roadblocks potentially have been, what's been really good about the experience, when going from one service to another or one place to another, what have been the barriers, what have been the enablers. And again, this could be spending the morning with somebody, so this is a little bit more time intensive, but doing that early on, you're going to get a lot of really good information about this experience. So, the other important point too is that consumers and their family or whānau, they often have a very different of experience of the journey. And so it might be useful to understand that as well. It might be useful to spend some time with the sort of the wider group together, or spend time with individuals and see what difference that makes to the experience as well. But of course, it is time consuming, but it does provide a lot of data about what actually happens in reality, not what's written down, or you may be able to see from some notes what's happening for someone, but to actually experience it with them is slightly different. And it's about what went well, and it's what would be even better, and also what can we do with these ideas that are captured. So shadowing, I haven't done too much of it myself, but I know that it's worked really well in a lot of co-design projects, and I'd really recommend thinking about using that. A note on data, sort of bigger data and smaller data. So of course, quantitative data has its place. So I wouldn't want you to think from the previous activity that just capturing the experience, not using scales is not the way to go. It's just, what fits what you're trying to achieve. So what this is an example of is the National Adult Inpatient Experience Survey, which has been running since about 2014. So it's captured a lot of information over that time. And what this is a run chart of the lowest rating questions in the 4 domains for this survey. And so what those low areas are, it might be a little bit hard to read from where you're sitting. One of them is about, did a member of staff tell you about medication side effects to watch for when you went home? One of them was, did the hospital staff include your family or whānau or someone close to you in decisions about your care? And the final one is, do you feel you received enough information from the hospital on how to manage your condition after your discharge? And if you could see these a little bit clearer, you'll actually see that not much has changed. So what it's showing is from 2014 to 2019, there have been some shifts, and some have argued that they are significant, but overall it hasn't changed too much really. And these 3 areas have been the lowest scoring areas over time. So the primary care, there's also going to be a primary care survey as well, which looks at similar things, but thinking about it in terms of lower scoring may not be the way to go for primary care. And the reason I bring this up is because if you look at one of the questions about medication, this is the only question that a patient, when they are discharged, can answer about medication, or one of the few that they can answer about medication. And so it was based on, so it could be compared with other jurisdictions, it was based on a question set put out by the Picker Institute, and so the question was not changed. And so this question about medication side effects, what we're thinking, because when we look at the qualitative comments, is actually people are seeing this question, they're seeing the word medication and going, there's something that wasn't quite right in my experience to do with medication, but this is the only opportunity I actually have to comment on that particular aspect. So, we could argue, not proven yet, but we could argue that it's not really about side effects, it's actually something else. Something else is going on about medication in that question. And when you look at the qualitative comments, that's exactly what you get, is more rich information about the experience, pointing you in different directions that in actual fact side effects were one of the least important, potentially. But if you were to just look at the high-level aggregated quantitative data, you'd be led to believe that it's all about medication side effects, when that in fact might not be the case. But experience questionnaires such as this still have their place, and I know many co-design projects that have done something as simple as put a survey monkey survey together or something and sent that around a particular service or a particular group partly to try and understand what to focus on next. That's really why it was done, to think, where should we take this? What I prefer is really the individualised data around the experience. And so some of you may be familiar with mapping emotions when thinking about a care journey. So what this shows is it shows arrival and check-in, information, waiting, going to theatre, in this case it's about going to theatre, recovery, check-up, and then leaving. And so for every point along the journey, there's an opportunity for somebody to circle how they're feeling at that point in their care journey. So you have words like happy, supported, safe, good, or comfortable, more on the positive side of an experience, versus words like in pain, worried, lonely, or sad. And there's a space as well for people to write their own words and their own feelings about the experience. There's arguments as well that, for some people, this is not going to be a very accessible way to get people's feelings and thoughts. So sometimes people use pictures in place of words. Sometimes people use the sort of sad face to the smiley face kind of situation. But there's also arguments against using that, which we could talk about. But really this, in all of the co-design projects that we've seen through our Partners in Care program, this has been one of the most common tools that's been used, and it's really been useful to point people in the right direction about experience. So I'm sure that many of you have heard about focus groups and are familiar with them. And really they're just a form of group interview that captures on communication between participants, but they have a different dynamic to them. A one-on-one interview versus a focus group, of course, will get you very different information, because people may not want to disclose to a group and within a group, but on the other hand, it might spark people to talk more about a particular experience when they see there's a commonality around that experience. Because the group interaction is really the key part of it, and it's just, instead of asking people to respond to a question, people are encouraged to talk to one another, exchange anecdotes and comment on other experiences and point of view. But as I say, this can sometimes lead to a group response, and it might be one dominant member of the group that then takes the conversation in a particular direction, and that's when the facilitation aspect's really important as well. So, the concept of a focus group is fairly straightforward, but sometimes we don't always think about what we need to do in advance to run a good focus group. And really it's the practical questions around, where should this focus group be held? Where's a space that actually works for everybody, that's kind of a non-threatening, comfortable place that you're going to do this? And how are we going to choose participants? How should we invite them? How much notice are we going to provide? How long should the focus group be? What do we need to prepare prior to the focus group? And what do we need at the venue? So really these are just very practical considerations about focus groups. But surprisingly these get left to the last minute quite a lot, and we're all guilty of that. So just important to think about if you want to use the focus group. There are a lot of benefits of running focus groups, because they don't discriminate against people who can't read or write. They encourage participation from those who are reluctant to be interviewed on their own, and they can also encourage contributions from people who feel they have nothing to say, or who are deemed the so-called unresponsive people in your communities. But also too, there are some cautions around using focus groups. The group can feel overwhelming to some, as I mentioned. There needs to be care taken around confidentiality of participants, and I'm sure that's very important for a lot of your projects as well, because they may share personal stories, and once they've shared them, that they may leave there needing to have a sort of follow-up conversation with you, because we know this might have unopened some things for people, and they might want to share more on a confidential basis. And they also require a level of expertise to facilitate, and need more than one facilitator even for small groups. And the day that I consider myself an expert facilitator, I'll let you know, because it hasn't happened yet. I think it's going to take a long time. So individual interviews, also very beneficial. And probably in these, it's really about the framing of the questions. We want to understand experiences, enable people to feel safe while they're sharing them. And it's really just using those concepts of appreciative inquiry. What went well? How did that make you feel? But what would be even better if? And how did that make you feel? And what would make that even better? I think a lot of the time when engaging with the community about the services and the care they receive, there can be that fear that what it's going to turn into is an opportunity for somebody to complain about the service or to complain about individuals in the service. And we hear that a lot, regardless of the specialty. It does worry still some people, not all, but there are still some who find this, and probably less so in this kind of group, but in others that it certainly is a concern. But, sometimes it's actually about people, of course, wanting to share their positive experience, which is just as useful to know. You may have two people who went through this, of course, the same service, had exactly the same service, but one didn't work for one and one worked for the other. And to understand the differences and why that was for this particular person or this particular group, is really, really valuable information. So, focus groups and individual interviews, I think are probably, there's some of the basics around getting and understanding that experience. So this is an example, and I must acknowledge, Dr. Lynn Ma for some of these slides, because some of them might be familiar to you, that Lynn Ma, who works at Counties Manukau, she's been doing co-design for many years for Kawawatea and a national program that we do through Partners in Care. So here's an example of a framing question. Hello, my name is, I'd like to start our conversation today at the point you knew that you were going to be discharged. So this is a discharge example. Can you tell me what happened and how did that make you feel? What happened next? How was that for you? And what do you think of the information you were given? Did anyone take you through it? How did that make you feel? What was it like for you when you got home? And so on. So that's really talking through somebody's experience. But when I look at this example, what I also think about is how much more rich information you could have got from shadowing somebody and actually spending that time with them, and then being able to note it down as well from your perspective and also from their perspective as well. And on top of that, also thinking about what kind of information you could get in a focus group if you were framing questions in this way in a group situation. Now, I've just put up an example, a mental health example here, which I don't know much about, but I can see the point of why it's here, which is about zero seclusion. And so what it's showing is really what I just talked about before, is the different ways of mapping the experience. So what this shows here, it's got preventing seclusion on the left, and it talks about early on in the community, and then moving to the right, it's got in the ward environment. Then it has how did it feel ending seclusion, and then your thoughts and feelings on seclusion. So the target here around zero seclusion 2020, and then all these different thoughts and emotions and feelings and ideas around that, all just captured, I'd say, in a relatively short space of time for this particular activity, but a lot of rich information here. So really, there's a lot of different ways that you can capture experience, including something like this. And really all this is a piece of butcher paper, it's some post-it notes, and it's a group of people together talking about different experiences. So there's nothing particularly complicated about it, but at the same time, in a relatively short space of time, you can get a lot of information about your project or about what you're trying to achieve. So I have an example here from last year, the cohort for our co-design program, and another for the Partners in Care program, was with Pegasus PHO. And so that really brought a lot of different random and diverse projects. We had everything from pathways for transgender health to youth self-harm. We had projects about improving discharge experiences. We had a lot of different projects, and traditionally in the past we'd focused very much in the DHB environment. Our projects had been based on talking to people and project teams in DHBs or in ward environments. And so this was the first time that we did one with a PHO. There's another program, a primary care program with the Commission as well, and they have a program called Whakakotahi, which is also about primary care improvement as well. And so there were a lot of really great examples actually on our website, lots and lots of co-design examples. Some that we've been involved with are also mental health examples, because it just goes with the territory of doing so many diverse projects. And so in the next two slides, one is really showing the value of the qualitative data in a project, and one is really showing how that qualitative data has really helped the team, this particular team, think about the common themes about youth self-harm. So what they wanted to do was they wanted to understand how they could improve their service for those that were accessing it, who were thinking about self-harm and who were of a particular, I think it was the youth age as an 18 to 24 sort of age group. And so what it says from a health professional here is we need to build links between secondary and primary and education services rather than isolate the support services. This requires negotiation around the sharing of information. So that's from the health professional perspective. So from the consumer perspective, somebody said, since the age of 13, I've worked with over 25 different counsellors, social workers, psychologists, psychiatrists and nurses. This has affected my willingness to open up and ability to trust in new relationships, and has severely impacted in the way I have been able to talk about my illness and the way I feel about myself. And so they're just two small examples, but already you can see there's a lot of information just in those two examples, both on the health professional and the consumer side. So if we look at some of the common themes, so the reason I'm showing you this is because some of the methods that I've mentioned in the previous slides were used by this team, and so this kind of shows what some of the end product can be. So youth self-harm, some of the common themes that came up for this particular practice were the need for more engaged follow-up, to look at repeat presentations and what to do there, better communication between primary, secondary care and consumers, more resources needed, education to address assumptions, better evaluation of services, change and instability within services, having a real impact for their client base, and cost and timeliness of access to support being barriers. Perhaps not unsurprising common themes to this room, but nevertheless, these were not gathered from a survey. They were gathered from looking at the patient experience and using a lot of those tools and methods that I showed you before. Now, this is a note on generalisability. This comes from a resource which is about the talks for the patient experience from the UK, and I'll provide the link to that resource after this talk. And what they show is if you look at one axis, it's talking about more generalisable or less generalisable, or on the left it's less descriptive or more descriptive. Now, I think that what this kind of does is, I think it leads to a bit of a hierarchy where some may think that if something's more generalisable and more descriptive, then it's better, and if something's less generalisable and less descriptive, then it's worse. But in actual fact, it really depends on what question you're seeking to answer that'll really mean whether this works or not. I mean, for instance, it notes here that patient stories are more descriptive, but they're less generalisable. But maybe we could challenge that assumption, because maybe after you've heard 3 or 4 patient stories, all from one service, you'll probably start to notice that a lot of the themes are really, really similar. So while it's only 3 or 4 people, in actual fact, there could be some generalisability to what people are saying. So this is really just to think about, is it really that surveys are more generalisable and therefore better, and patient stories are less generalisable and then maybe not as useful? It's a bit of a binary way of looking at things, and I think maybe things have moved on a little bit from that. But it's important maybe to ponder on that as well, because when you're making the argument and when you're putting your case studies together, these are the kind of questions that people ask about the applicability of what you're reporting, and whether it has the ability to spread and scale beyond your one project, or whether it can go out further. And now just a note on informed consent, and for this group, probably not that necessary to really say too much about it. But one thing to note, if it wasn't noted earlier, for quality improvement projects, informed consent in the sense of getting multi-centre ethics approval and in the sense of getting hospital approval or service approval is not required for anything to do with a quality improvement project. But of course that doesn't mean that just because it's not required in that official sense that these principles of informed consent don't apply. So really with informed consent it's simply, why are you looking for input and what do you plan to do with the responses? It's ensuring agreement to engage and understand how data will be used. Do participants wish to be informed of progress and outcomes? So in a co-design context, this should be straightforward because the participants and the team are all working together right from the beginning all the way to the end, just so long as the problem wasn't defined up front with one group and then another group was brought in later, as long as everybody was there from the beginning all working together on the same project. And also, how will people be compensated for time and contribution? And in some projects we've seen people haven't spent enough time thinking about this up front, and so they've got halfway through projects and haven't really had that consumer input because they haven't enabled a space where people can be compensated in some way for their time and for their contribution, because the very people that you want to hear from may be the people that are less likely or less able to be able to come along. So, in doing projects, that's a really important consideration. But as I say, in the sense of ethics approval, in that big process that some of you will have been through, that is not required for any co-design projects or any quality that are related to quality improvement. So that leads us full circle and really leads us back to the beginning. Hey, thank you very much for your time, and I hope all your projects go really well. You can contact any of us at the Commission if you have any questions about anything you've heard just now or anything you've heard today, and we'll be more than happy to help you. So thanks, and congratulations on getting to Friday, and have a good weekend. Thanks.